Kavi- Kavisha is our second year fellow, and she's going to be um, talking to us about uniparental disomy. I don't know why Kavisha always picks the most difficult genetics talks for fetal therapy. There's so much for us, all of us, to learn: faculty, fellows, um, residents, and genetic counseling students. So, welcome, Kavisha, and thank you so much. I do want to tell you that we do have to focus because this is a very, very difficult genetics mechanistic pathology to really understand. And Kavisha dissected it to the atom, basically. Thank you, Kavisha.
Thanks, Dr. Al-Kwatli. Hi, everyone. Today I will be discussing uniparental disomy, part 1, which means there will be a part 2. So to introduce the topic of uniparental disomy, I'd like to start off by discussing a patient case, actually from last year, patient KM. Patient KM is a 34-year-old G2P0 who presented for prenatal care at 9 weeks and 0 days at an outside hospital with plans to transfer care to Delaware. Her past medical history and obstetric history are non-contributory. At 12 weeks and 5 days, the patient underwent cell-free DNA screening, and the results showed the following. High risk for monosomy X with a fetal fraction of 12.0 and a positive predictive value of 70%. The patient then presented at Jefferson for prenatal care. At 13 weeks and 0 days, she underwent a first trimester ultrasound that demonstrated a normal MT. She underwent genetic counseling with discussion for monosomy X possibilities, including confined placental mosaicism, true mosaicism, and monosomy X in placenta and fetus. After discussion with our genetic counseling team, consisting of Stephanie Rice and Dr. Al-Kwatli, the patient decided to undergo amniocentesis. She underwent the procedure at 15 weeks and 0 days. Results were as follows. Karyotype demonstrated 46XX. Growth of cells, however, were poor, with only 2 cells available for analysis. Chromosomal microarray, however, demonstrated normal dosage, whole X chromosome homozygosity, female with uniparental isodisomy of chromosome X. Following the amniocentesis, patient and partner discussed findings with our genetic counseling team at 17 weeks and 5 days. The patient was then counseled that there was no evidence of residual monosomy in fetal cell. However, we cannot exclude low levels of mosaicism. Uniparental disomy increases the risk of imprinting disorder. At this time, however, there is no confirmed imprinted genes. However, chromosome homozygosity places the female fetus at risk of potential X-linked recessive disorders, such as Duchenne muscular dystrophy. Additionally, it is unclear if isodisomy is maternal or paternal in origin. Based on the conversation, the patient elected for referral to CHOP Center for Fetal Diagnosis and Treatment, and also underwent an analysis. At 19 weeks and 1 day, the patient followed with the CHOP Center for Fetal Diagnosis and Treatment. The anatomy ultrasound revealed a shortened corpus callosum, and the patient underwent genetic counseling with the team. There was no known imprinting disorder based on chromosomal microarray results, and they discussed the X-linked recessive and X-linked dominant genes, with main concern that 2 chromosomes are inherited from the same. Which is exactly what we had discussed with that team, for that couple. At 21 weeks and 1 day, the corpus callosum appeared normal in size at the ultrasound at CHOP. At 25 weeks and 2 days, the patient underwent an interval growth at CHOP that was normal. And then ultimately, at 41 weeks and 0 days, the patient underwent an uncomplicated vaginal delivery. Although this case did not have significant implications regarding clinical manifestations of isodosis.
So the baby is doing well as far as we know?
As far as we know, based on records. Although this case didn't have significant implications clinical manifestations of isodisomy X, I thought it would be a good case to discuss as it utilizes terminology important to understanding uniparental disomy. The goal of today's presentation is to obtain a better understanding of uniparental disomy and the mechanism of action, and explore the various clinical manifestations from chromosomes 1 through 11. For part 2 of my presentation, which will be later in the year, we will review chromosomes 12 to 23, sex chromosomes, prenatal diagnosis, and subsequent management. Moving on to definition and mechanism. As you may recall from my previous fetal therapy, regions of homozygosity refers to a continuous stretch of DNA where both alleles are identical, meaning the individual inherited the same genetic information on both chromosomes at that specific location, and these regions are typically identified using single nucleotide polymorphism microarray analysis, while remaining copy numbered. In other words, there is no change in chromosome quantity throughout the segment. Essentially, it's a homozygous segment detected without any changes in chromosome copy number. Regions of homozygosity include consanguinity, uniparental disomy, and autosomal recessive disorder. But for the purposes of today, we will only be concentrating on uniparental disomy. Under normal circumstances, 2 copies, paternal and maternal, of each autosome exist that carry discrete differences encoded by single nucleotide polymorphisms that can thereby be distinguished. In regions of uniparental disomy, portions of one of the chromosomes are lost and replaced by the exact copy of the remaining chromosome, whether this is paternal or maternal, resulting in retention of 2 copies of genetic information, but loss of polymorphic differences which existed due to the presence of maternal and paternal genes in this region of a diploid chromosome set. Now, the mechanism of uniparental disomy is much more complex than what I depicted in previous. I will, in fact, go through the different mechanisms in depth, but before I do that, I want us to review a few terms. Uniparental isodisomy, or UPID, and uniparental heterodisomy, or UPHD. Complete uniparental isodisomy means that there are 2 chromosomes that are identical with respect to all polymorphic units along the entire length of the chromosome. Complete isodisomy implies both absence of recombination and meiosis too. Complete uniparental heterodisomy involves the inheritance of 2 different sets of alleles that are present for the entire length of the chromosome. Complete heterodisomy implies an error involving segregation of chromosomes at meiosis 1. The state of iso or heterodisomy can allow for an inference as the site of the initial chromosomal error. Isodisomy, again, typically reflects meiosis 2 and is a non-disjunction or mitotic error, whereas heterodisomy is due to non-disjunction at meiosis. To better understand the different mechanisms, we also need to review meiosis. So meiosis is a specialized cell division process where a single cell undergoes 2 rounds of division, resulting in 4 daughter cells, each with half the number of chromosomes as the parent cell, also known as a haploid cell. In prophase 1, you have the chromosomes pair up and exchange genetic material through crossing. In metaphase 1, you have homologous chromosome pairs that line up in the equator of the cell. In anaphase, you have homologous chromosomes that separate and move to opposite poles of the cell. And then in telophase and cytokinesis, you have the formation of the 2 haploid daughter cells. In prophase 2, the chromosomes condense again. In metaphase 2, individual chromosomes line up at the equator of the cell. In anaphase 2, sister chromatids separate and move to the opposite pole. And then in telophase and cytokinesis 2, you have 4 haploid daughter cells that are formed. Now, there are 4 overall mechanisms leading to the state of uniparental disomy. I will start off by reviewing gamete complementation. So gamete complementation occurs when you have a non-disjunction event in meiosis, leading to the transmission of 2 copies of a chromosome to the gamete, which is then fertilized by a nullosomic gamete, so a gamete that doesn't have any chromosomes that are lacking that same chromosome. As a consequence of mitotic recombination, regions of both heterozygosity or heterodisomy and homozygosity or isodisomy are typically found. The solid rectangle indicates the imprinted gene inactivated on the maternal inherited copy. Inheritance of this gene from only the mother results in 2 inactive copies. Isodisomy may also lead to homozygosity for a mutation, which is indicated by this asterisk, which is carried by only 1 mutation. Although gametic complementation is an obvious mechanism that may result in uniparental disomy, it's difficult to prove in any particular case since the loss of one parent's chromosome may have occurred early in the development with no trace of the original progenitor cell line. Gametic complementation may be suspected if the non-transmitting parent is a carrier of a chromosome abnormality known to be at increased risk of segregation errors, as have been observed in several cases. The second mechanism of trisomic rescue the second mechanism is trisomic rescue or correction. It is the most common cause of uniparental disomy. The cause of trisomy is a typical mitotic non-disjunction that happened in one of the 2 conceiving parents. The rescue process takes place in the cell of the trisomic conceptus. The image above depicts fertilization of a disomic with a normal sperm results in a trisomic conceptus. Loss of the paternal chromosome in the somatic cell division would lead to maternal uniparental disomy in the derivative cell. In some cases, there can be up to 100% trisomic cells in the placenta, with most fetal tissue displaying only a normal chromosome complement. It's important to know that the mechanism of trisomy rescue can occur in many, many different ways as depicted above. The initial event in each of these scenarios depicted arises when a chromosome segregation error during meiosis, followed by a second rescuing segregation error in the zygote or an earlier embryonic division occurs. So if we look at figure A, we have these are the different mechanisms, so I'm just going to go through them. So in figure A, we have no recombination, non-disjunction error at meiosis 1, resulting in complete heterodisomy. In figure B, we have no recombination, premature separation of the chromatids, resulting in complete heterodisomy. In figure C, we have no recombination, a reverse segregation, which is basically when the sister chromatids separate in the first mitotic division or meiosis 1, instead of typical separations of the homologous chromosomes. And a segregation error occurs also in meiosis 2, resulting in complete heterodisomy. In figure D, you have no recombination, non-disjunction at meiosis 2, resulting in isodisomy. And then in figure E, you have recombination occurring, non-disjunction at meiosis 1, and that results in actually partial hetero or isodisomy. And then in figure F, you have recombination, non-disjunction at meiosis 2, resulting in partial hetero and isodisomy. So this is all to say that it is a very complex process and can occur in multiple different ways. The third mechanism is monosomy rescue. Monosomic rescue comes into play following non-disjunction event. If a nullosomic gamete is generated at meiosis, then the conceptus will be monosomic. Mitotic correction then takes place, and this is achieved by replication of a single normal homolog received from the other parent. In this case, the uniparental disomy will be an isodisomy. And the fourth possibility is a mitotic error in an initially normal conception, leading to either trisomy or monosomy. In the case of a trisomy, This is followed shortly thereafter by a loss in that cell line of the non-replicated trisomic chromosome. In the case of a mitotic non-disjunction resulting in monosomy, the remaining homolog is then duplicated. And then in both cases, the uniparental disomy is isodisomy. The mechanisms I discussed above contribute to complete isodisomy or complete heterodisomy. In addition to complete, partial, or segmental heterodisomy or isodisomy can coexist in the same chromosome. So segmental uniparental disomy may arise as the consequence of post-zygotic somatic recombination between the maternal and paternal. So for example, a crossover at meiosis 1, you can say the distal long arm, or in this case, it's actually the short arm, is followed by meiosis 1 non-disjunction. And this could lead for a disomic, isodisomic for the distal short arm in this case, and then heterodisomy for the proximal long. And so this all depends on if the non-disjunction was at meiosis 2 or meiosis 1, because that's going to determine if it's isodisomic or heterodisomic. So in this case, the classical karyotype is neutral, but you can have another mechanism of segmental uniparental disomy where you have mitotic non-disjunction producing a disomic gamete, a trisomic conception. Then you get mitotic crossing over between the maternal and the paternal chromosome. And this, then you have loss of one of those chromosomes because there's 3. And then that come with the disomic gametes. So then you have uniparental disomy that can have an effect if the particular chromosomal segment incorporates loci that's subjected to imprint. And if the recombination, I know this is a lot, occurs after the formation of the inner mast cell, which is what gives rise to the embryo, then the segmental uniparental disomy will only involve some cells. So then you get mosaic segmental.
Amazing any of us have normal genetics.
Correct.
Really?
Correct.
Probably don't. There's just so many opportunities for
There's
things to go wrong.
so many opportunities, which is why I had to take it back to meiosis to go back to this. This makes sense so far.
Now, could I replicate it? But it makes sense when you say it.
Can I do a repeat back? Probably not. That's for after this presentation.
Before like a School of Rock version of this.
They'll be after drinks. Before we go in depth through the clinical significance, I do want to discuss the clinical implications of the mechanisms of uniparental disomy that were discussed in the last several slides. So what's interesting is that many of these mechanisms for uniparental disomy involve a transient aneuploidy, and establishing phenotypic consequences of uniparental disomy are actually confounded by the possibility of residual mosaic chromosomes. So prenatal detection of whole chromosome disomy should therefore then prompt analysis to look for aneuploidy cell lines. And this may be indicated in some cases of postnatal detection of uniparental disomy, depending on the phenotype. So if it's like an abnormal, unusual phenotype, you also want to take a look for aneuploidy. In theory, if you have trisomy rescue, it can involve any 3 homologs present with an equal probability. So uniparental disomy should actually be present in a third of these. Again, should occur more often than you think. It's amazing that things work out. All mechanisms involving an initial mitotic error can be expected to actually be associated with advanced maternal age. This includes cases with uniparental disomy arising through genetic complementation, because there also needs to be complementing maternal mitotic segregation. And then a segmental loss of heterozygosity can be indicative of actually segmental uniparental disomy, or it may be actually bounded by regions of biparental. So you have like just this little region, and then surrounding it are actually normal biparental. And lastly, detection of isodisomy should always prompt consideration for an autosomal recessive disorder for a condition that maps to the region of concern. This, however, is not true for heterodisomy. It's true for isodisomy because you now have regions of homozygosity, essentially. So now that we hopefully understand the various different mechanisms contributing to uniparental disomy, let's discuss this clinical signal. So most chromosomes involving uniparental disomy do not, and this is important, result in a pathogenic manifestation. The abnormal phenotypes associated with uniparental disomy are mainly caused by disrupting genetic imprinting, by uncovering harmful autosomal recessive mutations, or by the presence of an occult aneuploid. Genetic imprinting is defined as specific chromosomes containing the imprinted genes, which are expressed differently depending on parental origin, through the mechanism of DNA methylation silencing. So genomic imprinting is a normal part of gene regulation in mammals, and it's an exception to Mendelian genetics. So that Hardy-Weinberg principle we discussed last time is one of the exceptions. This means that maternal and paternal genomes aren't functionally equivalent, and both are required for normal development. Homozygosity for recessive mutations in uniparental disomy, causing an autosomal recessive disease, can make pathogenic manifestations, especially when cases are detected with isodisomy. So for cystic fibrosis, there was several cases specifically in growth-restricted female neonates, or rather fetuses, that resulted from a mutation in the CFTR on chromosome 7 that was unmasked by maternal isodisomy. There's also a case of a female with a limb girdle that resulted due to POMT mutation on chromosome 14 that resulted in muscular dystrophy that was unmasked by maternal isodisomy. And there was a case report of the RET-REG1 mutation on chromosome 5 that was unmasked by paternal isodisomy that led to hereditary, sensory, and autonomic neuropathy. Now, the incidence of uniparental disomy in human conceptions is 1 to 2 in 1,000. It's important to note that the incidence of uniparental disomy in miscarriage tissue essentially is very, very 0.1 to 0.3%, and it's not considered to be a cause for early death.
That's basically the same as for human conceptions.
Yeah. Yeah, it's really interesting because I think what this says is that most actually end up progressing past this first trimester period thing. So yeah, we'll get a little bit more into that, but. So over the course of the next several slides, we're going to review the clinical manifestations of uniparental disomy associated with every single chromosome. We are going to start off with chromosome 1. So uniparental disomy of chromosome 1 is not associated with a specific phenotype. In the literature, over 10 cases of paternal uniparental disomy of chromosome 1 have been reported. The associations in the literature have been essentially with the diverse recessive disorders where the causative gene is located on chromosome 1. So there was a case report by Benko et al. In 2015 that discussed uniparental disomy resulting in concurrent Charcot-Marie-Tooth and Gaucher's disease. So in this case report, the patient was born at term to non-consanguineous parents with paternal family history of autosomal dominant Charcot-Marie Tooth. And the patient's presentation was moderate sensory hearing loss, old Parkinson white arrhythmia, bicuspid aortic valve, and motor delay. At 17 weeks, however, the patient ended up having hepatosplenomegaly and a bone marrow biopsy that led to the diagnosis of type 3 Gaucher's disease. However, there were other features of the child that were not exactly what you would expect for Gaucher's disease, and this led to genetic testing. And the testing showed complete paternal isodisomy, implicating this mechanism as the etiology of the concurrent disorders. So the reason I even discuss this case or bring it up is because it demonstrates how uniparental disomy should be considered as an explanation when you have rather unusual presentations of well-known disease. Moving on to chromosome 2, uniparental disomy for chromosome 2 has been rarely reported. In most reports, maternal uniparental disomy for chromosome 2, which trisomy 2 in mosaic, has been confined to the placenta, has been associated with FGR. Maternal uniparental disomy, which is more often heterodisomy, does not seem to be clinically relevant. In one case, however, maternal uniparental disomy had been actually associated with isodisomy and was responsible for a trifunctional protein deficiency. And there were also 5 cases of maternal uniparental disomy of chromosome 2 that resulted in 5 cases. 4 of the cases had FGR. 3 had atypical bronchopulmonary dysplasia, and 2 had hypospadias. And then there were 2 cases specifically of the paternal uniparental disomy. One was in the setting of a case report by Petit et al. In 2004 that reported a case of a male infant affected by Crigler-Najjar syndrome, and a case report by Castiglione in 2009 that reported a case of isodisomy of the ABCA12 gene that resulted in harlequin ichthyosis. So this is kind of just reiterating is like if you have isodisomy, you're at increased risk of now having these autosomal recessive disorders. In chromosome 3, there have been no paternal or maternal cases of uniparental disomy that have been associated with a phenotypic disorder, suggesting that there are no maternal or paternal imprinted genes causing rare genetic disorders. There, however, was a case report in 2006 that noted complete maternal isodisomy in a child with recessive dystrophic epidermolysis bullosa. For chromosome 4, maternal isodisomy or heterodisomy may be without a specific phenotype, except for cases of homozygosity for a recessive disease mutation. There was a gene linkage study, interestingly enough, that found that duplication of chromosome 4 associated with like maternal isodisomy may actually be placing patients at risks of mood disorders. In the patient described, the proband siblings and parents had normal chromosome 4 genotypes, except for a small expansion of a pericentric area in the maternal DNA. And what was thought was that the isodisomy of uniparental this area was associated with complete unmasking of recessive alleles on the affected chromosome. And this is actually what now led people to think that abnormalities in chromosome 4 could actually be implicated in major depressive episodes. Paternal isodisomy or heterodisomy of chromosome 4, however, has been scarcely reported. For chromosome 5, maternal and paternal isodisomy does not have a specifically associated phenotype, except for cases, again, of homozygosity for a recessive mutation. So here we have 2 specific cases. One was by Nomata, which reported a 10-year-old Japanese girl with Netherine syndrome in autosomal recessive type of ichthyosis. And then there was a case by Park that noted a 22-year-old female with an autosomal recessive disorder of hereditary sensory and autonomic neuropathy that was inherited from a carrier father and paternal isodisomy. So for chromosome 6, maternal uniparental disomy is rare, with a total of 20 cases reported in the literature with actually variable clinical presentations. Among the 16 cases, however, 13 cases did present with fetal growth restriction as the most common case. 10 cases of the 16 were combined with other anomalies, including oligohydramnios and malformations in brain, heart, face, and genitalia. And preterm birth and low birth weight were reported in 8 of the 16 cases, with developmental delay shown in 7 cases. And postnatal phenotypes, however, varied considerably due to the ranges of time spanning from neonatal to 52 years. Placental findings, however, were not documented in majority of the cases, but there was placental insufficiency reported in 3 cases and mosaic trisomy 6 observed in 2 cases. There also was, amongst 10 separate cases, 6 cases of autosomal recessive diseases due to isodisomy of maternal uniparental disomy 6. And then there were 3 cases that also showed, again, mosaic chromosomal anomalies. Findings from this study, however, noted that essentially you're having this like pretty big association with FGR and preterm delivery. So it's thought that maternal uniparental disomy of this chromosome may actually contribute to FGR through multiple defects. But based on the available information, it's hard to actually find the location on chromosomes to determine what is that precise association, so more research. On the other hand, however, paternal uniparental disomy is associated with a disorder called transient neonatal diabetes mellitus. So transient neonatal diabetes mellitus occurs when the offspring inherits paternal duplications within the long arm of chromosome 6. So this is 6q23.24. Prior studies have demonstrated that all patients with paternal uniparental disomy showed a complete lack of methylation at that site, as did 2 additional patients with transient uniparental disomy and no other chromosomes. This finding suggested that methylation defects at this locus could be causative and has further strengthened the likelihood of an imprinted gene being involved. So overactivity of one of the paternally expressed imprinted genes in this region, PLAGL1, is believed to be the cause of the 6q24 related transient neonatal diabetes. It's not really well understood how overexpression of the PLAG1 and other genes in the 24 region causes this transient neonatal diabetes mellitus. And also interestingly, like why this condition improves after infancy. But what we know is that the protein produced from the PLAGL1 gene helps control other proteins called the pituitary adenylate cyclase activating polypeptide receptor, or PACAP1. And one of the functions of this protein is to stimulate insulin secretion by the beta cells. So transient neonatal diabetes affects 1 in 200,000 to 1 in 400,000 neonates. People with the 6q24 related transient neonatal diabetes mellitus experience severe FGR in there was a study that demonstrated the mean birth weight 30 infants, and it was 1,930 grams at 39 months. Very, very restricted. Hyperglycemia may be identified by chance during routine investigations in the newborn period for a sick, dehydrated infant. Infants rapidly become dehydrated and usually require insulin. The diabetes may be actually resistant to treatment, and occasionally insulin is not required because all these neonates really need is rehydration. Signs and symptoms of this form of diabetes, again, is transient. They gradually lessen over time and generally disappear between the ages of 3 months to 18 months. But the important thing to know is that the diabetes may actually reoccur. However, usually during childhood illnesses or pregnancy. So up to half of individuals with 6q24 related transient neonatal diabetes develop permanent diabetes later. The average age of recurrence in a series from 2000 was 14 years, coinciding with puberty. Some individuals require insulin, others are treated with oral drugs or diet alone. And then other features that are related to this transient neonatal diabetes that can occur in some individuals include macroglossia and an umbilical hernia, malformations of the brain, heart, kidneys, hypotonia, developmental. Moving on to chromosome 7, paternal isodisomy or heterodisomy is also not really associated with a specific phenotype. However, maternal uniparental disomy is associated with Silver-Russell syndrome. So there are different genetic causes that can actually lead to Silver-Russell syndrome. One is maternal uniparental disomy for chromosome 7, or you can also have structural 11p aberrations and epimutations. In patients, however, that are born to mothers that are 35 years of age and older, so AMA, half the cases are due to maternal uniparental disomy. So this again reflects a maternal meiosis 1 error as the underlying. The incidence of Russell-Silver syndrome is estimated to be 1 in 30,000 to 1 in 100,000. And the syndrome is typically characterized by gestational growth restriction, resulting in affected individuals to be born small for gestational age with relative macrocephaly at birth. And they have a prominent forehead with frontal bossing and body asymmetry, which you can kind of see here. Like you see like the one leg that's long and the shorter leg on the other side. This is then typically followed by postnatal growth failure. And in some cases, you have, again, this progressive limb length discrepancy, feeding errors, or feeding difficulties. Other clinical features include triangular faces. You have fifth finger clinodactyly, micrognathia, cafe au lait spots or skin changes. And except for the limb length asymmetry, growth failure is typically proportionate and head growth typically becomes normal, even though these babies start off as with the average adult height in individuals that are untreated is about 3 standard deviations below. So very, very small. There's a specific scoring system that's sensitive in the diagnostic for the diagnosis, and clinical diagnosis can be established if an individual meets at least 4 of the specific criteria. So this is prominent frontal bossing, relative macrocephaly, plus 2 additional findings that were previously discussed, and as long as other disorders have a pulse. So management for this disorder involves a multidisciplinary team for early specific interventions, specifically involving early referral to an endocrinologist. So treatment, and that's because treatment involves growth hormone. So you can see like this is a growth chart, and this red line depicts where the child was off the growth curve. So way less than the 10th percentile. And then once they started growth hormone, you saw an increase and return to at least the 10th percentile. Additional treatment is also making sure that you manage the hypoglycemia. And again, this is all because of the feeding issues. So they need to see nutrition, have caloric supplementation, medication for GI, reflux, for GERD, and then you might also have to give like cryptoheptadine for appetite stimulation. For the lower limb length discrepancy, it also involves intervention, and in patients that are older that are affected that haven't been treated, sometimes you have to do distraction osteogenesis, which is like when you break the bone and pull apart. For severe micrognathia or cleft, it has to be, of course, managed by a multidisciplinary team involving craniofacial surgery. You can have males with hypospadia should be seen by a urologist. These individuals that are affected, males specifically, can have micropenis. So I know that we had a recent case here in ultrasounds. So also to consider, like in terms of genetic etiologies. They'll need physical occupational therapy, language therapy, and psychologic counseling to address psychosocial and body image issues. In regards to chromosome 8, maternal uniparental disomy has been associated with early onset ileal carcinoid, beta hydroxylase deficiency, hearing loss, muscle weakness, visual impairment, and ataxia. Paternal uniparental disomy, however, has been associated with Brown-Violetto band layer syndrome, which basically is a combination of muscle weakness, hearing loss, visual impairment, and ataxia. In terms of chromosome 9, previously uniparental disomy had only been associated with cases of trisomy 9 or mosaic trisomy 9. However, now there's been several case reports that have noted the association with fetal growth restriction, atrial ventricular septal defects, developmental delay, muscular hypotonia, and juvenile amyotrophic lateral sclerosis. Maternal and paternal isodisomy and heterodisomy may be without any phenotype except from a case, again, of homozygosity of recessive diseases. Uniparental disomy of this chromosome has been so scarcely reported that there is only one case in the literature of complete paternal isodisomy that resulted in junctional epidermolysis bullosa intermedium. In this patient, they had a complete paternal isodisomy of the COL1-781 mutation that led to a phenotype of scalded skin appearance, extensive skin erosions of extremities with excoriation and exposure of the blood vessels, left lower ankle joint deformity, and weak muscle reflexes. This was all at birth, as noted, all these findings. And then the last chromosome that I will be discussing today is chromosome 11. Now, maternal uniparental disomy is associated with silver vessel syndrome, the syndrome that I had just discussed. So it's also
7 and 11.
7 and 11, so easy to remember. And really what it is, it's the lesion at the 11p15. So if you have an imprinted gene and in the maternal portion, it's associated with silver vessels. So those are the two that you want to think of. And what this suggests is that, again, there's a mitotic non-destruction followed by trisomic rescue, leading to this phenotypic manifestation. Other things that are interesting too is that unlike the last maternal UPD for chromosome 7, when it occurs in 11, you don't have the body asymmetry. So what's interesting is, like, depending on where the imprinting occurred, even though it's on similar overall disorders, it does impact the phenotype. And this is actually important and true for the next condition I'm going to discuss, which is what the association is with paternal uniparental disomy, which is Beckwith-Wiedemann syndrome, which we've discussed previously. Beckwith-Wiedemann syndrome involves molecular aberrations within clusters of imprinted genes on chromosome 11p, specifically in the P15.5 to 15.4 region. So about 80% of patients with BWS have a known molecular defect in the 11p15 region, most commonly due to aberrant DNA methylation. Normally, the paternal allele is methylated at 1C, or rather IC1, and the maternal allele is methylated at IC2. These methylation marks are established in the germline and must be maintained throughout the reprogramming that occurs post-fertilization in the zygote. Gain of methylation at IC1 on the maternal allele leads to downregulation of H19 and expression of IGF2 on the maternal allele. Now, if you have loss of methylation on the IC2 of the maternal allele, this leads to repression of a certain gene and then downregulation of CKD-K1C on the maternal allele. So 20% of patients with BWS develop the disease in the setting of paternal uniparental disomy. The extent of the disomy can range from segmental to genome-wide, but with regards to the 11p15 region, paternal uniparental disomy leads to overexpression of the IGF2 and decreased CDKN1C expression as demonstrated in this image. Paternal uniparental disomy can be caused by errors in meiosis 1 and 2 in the gametes, or more frequently post-zygotic errors of mitotic recombination during earlier embryogenesis. So even though you have like formation of the zygote, you can have still errors that occur afterwards that can lead to falseness. So in general, Beckwith-Weidman syndrome is characterized by its growth disorder that can include macroglossia, hemihyperplasia, omphalocele, neonatal hypoglycemia, macrosomia, embryonal tumors like Wilms tumor, hepatoblastoma, neuroblastoma, rhabdomyosarcoma, kidney abnormalities, urecreases, and are the main conditions. It's considered to be a clinical spectrum, and what I mean by that, in individuals can have one or two or more clinical features. The clinical diagnosis of BWS can be established in a proband who has 2 tier 1 characteristics. So this is the macrosomia, the omphalocele, the lateral overgrowth. Lateral overgrowth meaning like half the body is overgrown compared to the other body. So you can kind of see that here where this leg looks larger than this limb. And then there is tier 2 criteria, which is the ear creases that you can see right here, kidney abnormalities. So why I bring this up is because determining the molecular subtype of BWS is important because there are correlations between the clinical phenotype and the genotype. So the image above depicts facial phenotypes of patients with different molecular subtypes. So for example, loss of methylation at 1C2 results in a phenotype demonstrated in image A, and will typically present with omphalocele macroglossia and nevus simplex, and has the lowest incidence of tumors. However, if you have a patient with BWS, due to paternal uniparental disomy, they will have the phenotype that is demonstrated in image D, which is the lateralized overgrowth and hyperinsulinemia, and they actually have a higher incidence of tumors. So BWS is a very complex topic that can be a full fetal therapy, but I won't go into it in detail. So hopefully this helps to show, however, that the mechanism of the genotype has great influence on the fetal. And we will do the rest of the chromosomes in April. And that is it.
Great topic. Many of the anomalies had fetal growth restriction, therefore the importance of opening amnio and genetic evaluations on how we identify anything. It could be minor, but over and hopefully the patient sometimes they accept and they can find the reason.
Thank you for this amazing talk, Dr. Khanuja. This is like, I think this is a topic that will actually be very difficult for maternal fetal medicine genetic fellows to dissect. And I think Kavisha did an amazing role dissecting this topic. There's so much for us to learn about uniparental disomy. Dr.